In this episode of Strong Diagnosis, I'm going to discuss the threshold model of decision making. Why are we talking about the threshold model? Well, it helps to understand why differential diagnoses in practice tend to be relatively focused and not a non-prioritized 30-item list of every conceivable possibility. It helps to understand when a test should be ordered and how to decide which test to choose. It helps to understand the concept of empiric treatment. And last, and probably most importantly, it helps to understand how to make clinical decisions in the presence of diagnostic uncertainty. Let me introduce a short clinical vignette. A 65-year-old woman with no significant past medical history or recent sexual activity presents with dysuria and hematuria for 3 days. She denies urinary frequency and vaginal symptoms. Review of systems revealed an unintentional 5-pound weight loss over the last 3 months. Her social history is notable for 40-pack years of smoking. Her exam is unremarkable. Just from that brief vignette, we could next ask, does this patient have a urinary tract infection? Should you as the clinician order a urine dipstick with or without urine microscopy, urine culture, both or neither? And should you start an empiric antibiotic while any test results are pending? To a clinician who has been practicing for a while, these questions might seem obvious or intuitive, but is there any way to analyze and justify the conclusions from that intuition? We're going to circle back to this case in a little bit, but first we need to explore what it means when we say a diagnosis has been ruled out or ruled in. Clinicians of all kinds use these terms every day with both colleagues and patients, but we rarely think about what those concepts truly mean. For example, if a clinician were to tell a symptomatic patient that they've ruled out multiple sclerosis in their case, what the clinician is usually trying to say is that they are sure enough the patient doesn't have multiple sclerosis that they're going to not worry about it anymore. But how exactly sure is sure enough? One might formally define the term ruled out as follows. A diagnosis is ruled out when the probability of that disease is low enough that the balance of anticipated benefit and anticipated harm argues against further testing for it. Not all the consequences of this definition will be intuitive. The most obvious consideration that one should have when determining where to draw that line of probability, that is, how unlikely does the diagnosis need to be in order to rule it out, is the severity of the diagnosis. For example, for a patient presenting to the ER with chest pain, the probability of a life-threatening condition like a myocardial infarction or aortic dissection has to be much lower for the clinician to consider them ruled out as compared to the probability of benign conditions like costochondritis or esophageal spasm. For many clinicians, this is the only conscious consideration, but there are, or at least there should be, others. One of the less obvious considerations is the effectiveness of treatment for the diagnosis under consideration. For example, consider the extremely rare neurodegenerative condition Creutzfeldt-Jakob disease. It is universally fatal, so by that first consideration, you'd think it would have to be really hard to rule it out, but it also has no treatment. So in other words, if a clinician misses the diagnosis, the main downside to that is the patient will be presumably subjected to more testing for alternative explanations for whatever symptoms they presented with. That's obviously not great, but the adverse consequences from missing the diagnosis of Creutzfeldt-Jakob disease is nowhere near as bad as that from missing an MI or a dissection. If the relevant tests for a particular diagnosis are very risky or very expensive, that would increase the anticipated harm of additional testing, arguing against doing so. Another way that may seem a little bit more intuitive to look at these is that even if a diagnosis is relatively unlikely, if there's a quick, easy, cheap, and extremely safe test that would decrease the probability just a little bit more, it might be worth doing before ruling out that diagnosis. One also must consider any potential public health risk from missing the diagnosis. For example, if considering a diagnosis like tuberculosis or COVID, the probability must be particularly low before declaring the diagnosis ruled out, because that would mean removing the patient from isolation, potentially exposing others to the contagion. In summary, as a general rule, the threshold to declare a diagnosis ruled out is lower if it's not a life-threatening condition, if the risk-benefit ratio of treatment is unfavorable, and if there are no low-risk and cheap diagnostic tests. But there is one final consideration here, which is sometimes called patient preference, but which I think is more specifically labeled the patient's risk tolerance. This refers to how much uncertainty about a specific diagnosis the patient is willing to tolerate. For example, if you told a patient that they had a 2% chance of having a pulmonary embolism, many patients would be okay not pursuing additional testing with a CT angiogram. However, if a patient's close friend recently died from a pulmonary embolism, that 2% may not be low enough for them to feel comfortable with not doing more testing. Other patients may not have a concern about a single specific diagnosis, but may be excessively concerned about all potentially fatal diagnoses, or just feel uncomfortable with the idea of uncertainty. There are obviously limitations to how much patient risk tolerance should influence decisions about diagnostic testing. For example, if a patient presents to the ER with a classic migraine headache, but is really concerned that they have a brain tumor, no doctor should be ordering a brain MRI just to be sure, because the probability that the patient has a brain tumor might be like 1 in 10,000. But for borderline situations, where a clinician could reasonably go either way on whether to order additional testing before considering a diagnosis ruled out, how concerned the patient is can, and in some cases should, influence that decision to some extent. From that list, you probably have already realized that ruling out a diagnosis, it does not mean that its probability is literally 0%, a fact that clinicians can take for granted, but which can catch laypersons off guard. Now, what about ruling in a diagnosis? Well, there's sort of some parallel structure here. So a diagnosis is ruled in when the probability of that disease is high enough that the balance of anticipated benefit and anticipated harm argues against further testing for it. The biggest consideration here is the probability and potential severity of alternative plausible diagnoses. This is because once you've ruled in a diagnosis, that generally means that you stop looking for alternative explanations for the patient's presentation. If you're going to diagnose a patient with heartburn, you need to be really sure that they don't have an MI. Another way to think about this consideration is that in general, you can't rule in a diagnosis without simultaneously ruling out everything else on the differential. I say in general because patients can present with more than one disease process at the same time. A patient can present simultaneously with esophageal reflux and an MI, or for that matter, a patient theoretically could present with a migraine headache and a brain tumor. But it's uncommon for that to happen outside of a handful of often observed exceptions, like the co-presentation of pneumonia and lung cancer. Another consideration with ruling in a diagnosis is the toxicity from treatment. This comes up all the time with cancer diagnoses. You don't want to subject a patient to chemotherapy unless you're really sure of the diagnosis. Analogous to the ruling out considerations, we should also consider the risk of harm and the cost of relevant tests. Imagine a patient has a 95% chance of a certain diagnosis. If there is a cheap, non-invasive test that could bump that probability up to 98% if positive, you might consider 95% not high enough to be ruled in, depending on how serious the diagnosis is and what treatment looks like. Whereas if the only relevant test cost $5,000 or was invasive and carried a non-negligible risk of death, in that case, maybe 95% would be good enough. You also want to consider the psychological impact from the diagnosis. For a patient presenting with urinary symptoms, they'll probably be fine to hear that they have a UTI. But diagnosing them with gonorrhea, particularly when that patient thought they were in a monogamous relationship, that would be a much heavier news to bear. So this is just one reason why we sometimes diagnose a UTI based on symptoms alone, but we would never diagnose a sexually transmitted infection without specific testing, even if the diagnosis seemed overwhelmingly apparent from just the history and exam. There is again the public health consequences for making an erroneous diagnosis. In this case, if you diagnose a patient with tuberculosis who doesn't actually have tuberculosis, it could result in a lot of unnecessary testing for a whole bunch of people. And last, you again want to consider the patient's risk tolerance. As a general rule, the threshold to declare a diagnosis ruled in is lower if alternative explanations are either highly improbable or if they are not life-threatening, and if treatment for the disease in question is relatively safe. And again, as you probably realize by now, ruling in a diagnosis, it doesn't mean that its probability is literally 100%. A ruled out diagnosis can be reconsidered if newly acquired data makes it more probable than it was at the time it was ruled out. That newly acquired data can be information gleaned from a test ordered for another diagnosis, or that newly acquired data can be the fact that you've since even more definitively ruled out diagnoses that were initially more likely. Now, there are a lot of analogies that one can make between the classic stories of Sherlock Holmes and clinical reasoning. This one Sherlock Holmes quote I feel like is particularly relevant here. Once you have eliminated the impossible, whatever remains, no matter how initially improbable, must be the answer. And this brings us to the concept of a diagnosis of exclusion. A diagnosis of exclusion is a diagnosis that is easier to rule in by ruling out alternative explanations than it is by directly testing for it. This is usually because the diagnosis has no specific diagnostic test of sufficient statistical strength, or because there is no real diagnostic test at all. For example, diagnosing a patient with something called somatic symptom disorder, in which a psychiatric disease manifests as physical symptoms experienced by the patient, that diagnosis requires that non-psychiatric diseases first be ruled out, because there is no diagnostic test specific for somatic symptom disorder. Let's summarize what I've discussed so far with a basic figure. Consider a balanced scale in which we weigh the net anticipated harm of being wrong about a diagnosis, either erroneously ruling it in or out, against the net anticipated harm of additional testing for that diagnosis. What's meant by net anticipated harm is the summation of the probability of each potential harm times the magnitude of that harm. So, for example, a relatively high probability of missing a relatively minor diagnosis could be equally harmful as a relatively low probability of missing a relatively serious diagnosis. If the net harm of being wrong about a diagnosis is greater than the net harm of additional testing for that diagnosis, in that case it favors more tests. Whereas if the net harm of additional testing is greater than the net harm of being wrong, it favors either ruling in or ruling out the diagnosis based on available information without more testing. But here is the key. If the net harms of both sides are equal, then either choice, more tests or no more tests, is equally justifiable. That is, the probability of disease and our response to that probability is sitting at a threshold, which finally brings us to the threshold model itself. The probability of a specific disease in a particular patient who is presenting with some combination of symptoms, exam findings, and/or lab abnormalities exists somewhere between 0 and 100%. There are several probability thresholds at which a clinician is indifferent as to which of two strategies to pursue, that is, probabilities at which our scale is perfectly balanced. The test threshold defines the boundary between when a clinician would order tests to evaluate the presence of a disease, or when a clinician would decide that additional testing is not warranted due to all of the aforementioned reasons, such as the disease being too improbable or not being particularly dangerous. The treatment threshold defines the probability of disease at which the doctor is indifferent as to whether treatment should be prescribed. At probabilities above the treatment threshold, the benefits outweigh the risks of treatment. At probabilities below the treatment threshold, the risks of treatment outweigh the benefits, usually because we aren't sure enough the patient has the disease we would be treating. So at the treatment threshold, either treating for the disease or not treating for the disease are equally justifiable. You may have already realized this, but the test threshold, the probability of disease below which testing is unjustified, is the point at which we would rule out the disease. Thus, we can also call this the rule-out threshold. But the treatment threshold is a little trickier. One might assume, based on a desire to have parallel structure to our diagram, that the treatment threshold is the same as the rule-in threshold. And in fact, in most published descriptions of the threshold model of clinical decision-making, this is how it's presented. And these two thresholds, whether you call them the test and treatment thresholds or the rule-in and rule-out thresholds, define a region of probabilities in which testing is typically appropriate. In short, if a disease has neither been ruled in nor ruled out, additional testing is usually warranted. But here's what the problem is with this common version of the model. There are actually many circumstances in which you would decide to treat for a disease before it has been ruled in, meaning the treatment threshold is often lower than the rule-in threshold. The most common scenario in which this will be done is if the test necessary to rule in a diagnosis takes a while, during which the patient could have an adverse outcome if treatment is being withheld. For example, for a patient in the ER with high fever and unexplained hypotension, we would probably prescribe antibiotics before blood cultures and other tests for infection were resulted. As may be obvious, the treatment threshold is not just specific to the patient's presentation, but also to the treatment under consideration. So for a diabetic patient who presents to the ER with 30 minutes of crushing substernal chest pain, that information alone may be sufficient to provide the patient with an aspirin to treat a possible MI, since aspirin has a very favorable benefit to harm ratio in heart attacks. However, we would need more data before starting meds such as heparin or clopidogrel, since they have somewhat less favorable benefit to harm ratios. The better the benefit to harm ratio of a treatment, the less probable the disease needs to be in order for the treatment to be logical. Whenever we are in one of these circumstances in which we believe the probability of a disease lies above the treatment threshold for a specific treatment, but below the ruled-in threshold, that treatment is often referred to as empiric treatment. In other words, empiric treatment is any treatment for a disease that's begun before that disease has been ruled in. Overall, the treatment threshold depends upon the net anticipated benefit of treatment, the net anticipated harm of treatment, the cost of treatment, and the risk preference of the patient. Regarding risk preference, in this case, risk-adverse individuals would logically prefer lower treatment thresholds. The reason for this is that risk-adverse individuals prefer decisions which lead to greater certainty of outcome, even if that outcome would be worse on average. So somewhat oversimplified, as compared to risk-tolerant individuals, a risk-adverse individual will prefer mild side effects and cost from a potentially unnecessary medication, rather than risking a bad outcome from an untreated disease that they probably don't have. At this point, we have three thresholds which define points where the clinician should be indifferent to what course of action to take. And if the probability of a specific disease falls into the region between the rule-out and rule-in thresholds, and if all other things such as cost and risk of relevant tests are equal, the test chosen should be the one most likely to shift the probability across a threshold. In other words, order the test that is most likely to change management. So if the disease probability is here, closer to the rule-out threshold, we would look for a test that had a low enough negative likelihood ratio that the post-test probability of disease following a negative test result would allow us to rule it out. And if the disease probability is here, closer to the treatment and rule-in thresholds, we would look for a test that had a high enough positive likelihood ratio that the post-test probability of disease following a positive test would either allow us to rule it in or at least justify starting empiric treatment. So at this point, let's return to the brief vignette from the beginning to apply the threshold model. To remind you, we have a 65-year-old woman with no significant past medical history or recent sexual activity who presents with dysuria and hematuria for 3 days. She denies urinary frequency and vaginal symptoms. Review of systems revealed an unintentional 5-pound weight loss over the last 3 months. Her social history is notable for 40-pack years of smoking. Her exam is unremarkable. and we need to make decisions around the possibility of her having a UTI. Let's take a look at a probability threshold graph for this specific situation. First, what is the rule-out threshold for a UTI in her? The patient seems healthy, aside from the smoking, and UTIs are usually not life-threatening problems. Both of these features makes missing the diagnosis of a UTI less dangerous, arguing for a relatively high rule-out threshold. But testing for a UTI is non-invasive and inexpensive, which argues for a relatively low rule-out threshold. Therefore, we might put the rule-out threshold at about 5%. In other words, if based upon the history and exam, the probability of a UTI was 5%, the clinician would be indifferent as to whether to consider the diagnosis ruled out. This value is a bit arbitrary, and if you were to ask a large group of experienced clinicians what their rule-out thresholds would be for this patient, I would guess that it might vary from 2 to 10% or so. But to demonstrate how this works, I need to pick a number, and for me, for this patient, it's 5%. Now, where is the rule-in threshold? There's no reason to expect a significant psychological impact from a diagnosis of UTI, which argue for a relatively low rule-in threshold. But also remember that ruling in a disease usually means that you've ruled out all alternative explanations, and thus stop testing for them. Therefore, the rule-in threshold is partially determined by the individual probabilities and rule-out thresholds of these competing diagnoses, which includes a consideration of their severities. The competing diagnoses in this patient aren't many. A kidney stone, for example, is one common thing that could cause dysuria and hematuria, but missing a kidney stone isn't usually that big of a deal. However, the other major concern in a patient with new onset hematuria is bladder or kidney cancer. Statistically speaking, these are not very common causes of hematuria, but she does have a significant smoking history, which is a risk factor for both of these cancers, and she does have the small but unexplained weight loss. And cancer is a big problem if missed. Because cancer is a viable competing diagnosis, which, while unlikely in absolute terms, is still more likely in her than with the average patient presenting with UTI-like symptoms, the rule-in threshold for a UTI in this specific patient is relatively high. As with the rule-out threshold, the precise rule-in threshold is arbitrary, but I might put it at 95%. If there was an easy way to rule out cancer separately from ruling in a UTI, then I would explore that option in parallel, and if cancer was fully ruled out, my rule-in threshold for a UTI would be much lower. But directly and independently ruling out kidney and bladder cancer would require a CT scan and cystoscopy respectively, so that's not going to be the way to go here. Last, where's the treatment threshold for this patient? The treatment for uncomplicated UTIs in women is typically several days of an oral antibiotic. If this patient were at my own hospital, based on our local susceptibility patterns, there would be several options that are inexpensive and have low rates of significant side effects. So in other words, antibiotics will be cheap and safe, which suggests a low treatment threshold. But to be honest, most UTIs would resolve even if not treated, which argues for a higher treatment threshold. Overall, I'd feel comfortable giving her antibiotics for a possible UTI if its probability was, say, greater than 40%. Again, yes, 40% is arbitrary. Something that's important to realize with setting these thresholds is that we have not considered the patient's risk tolerance because this is a hypothetical case and we don't actually have a patient to talk to about this, but their risk tolerance could nudge each of these a little bit in either direction. For example, if the patient was unusually apprehensive about cancer, the rule-in threshold would get nudged up a little bit. And if they were unusually apprehensive about not treating a potential infection and was willing to tolerate medication side effects and toxicities, the treatment threshold would get nudged down. Now, the big question is, what is her pretest probability of having a UTI based on only her history and exam? For most diagnoses, we don't have a precise way of estimating this. This is part of the art of medicine. But there actually is a bit of data on UTIs, a discussion of which is beyond the scope of this video, but I'll drop a relevant link or two into the video description. Overall, based on the literature, not just based on my experience, but based on the literature, I would put her probability of a UTI at around 60%. So now, let's think about our questions. Does this patient have a UTI? This is an easy question. She probably does, but we don't know yet. The probability falls below the rule-in threshold. We'll skip the hard question for a second to next address antibiotics. As 60% falls well above our treatment threshold, we should give her empiric antibiotics. But now, should we order any tests? That's also straightforward. To some extent, yes. The current UTI probability is sitting in between the rule-in and rule-out thresholds. So then, which test or tests should we order? That is, what is the minimum combination of tests that will push the probability of UTI either lower than our treatment threshold or higher than our rule-in threshold? You will need to look up data on this, which will be included in the video description. But in short, a urine dipstick alone, if totally normal, could push the probability down just below 40%. But unfortunately, even a markedly abnormal urine dipstick doesn't quite have the statistical strength to push the probability above our rule-in threshold of 95%, which again is unusually high for a suspected UTI because of the specter of cancer in her particular case. So at the very least, I'd say this patient should have both a urine dipstick and urine microscopy, where they actually look for the presence of white blood cells under a microscope. If the dipstick showed either nitrites or leukocyte esterase and showed at least 10 white blood cells per high-powered field on microscopy, you could possibly rule in a UTI and be done. But when you crunch the numbers, it does end up being kind of close. And if the patient was risk adverse and particularly concerned about her cancer risk, it would be justifiable to throw in a urine culture too. As an alternative to urine culture, one could instead opt to check a UA with or without microscopy now, without culture, and then reassess her after antibiotic treatment. If her symptoms, including the hematuria, resolve after antibiotics, that increases the probability that she had a UTI and decreases the probability that the hematuria was due to cancer, possibly to the point of UTI being ruled in while cancer is ruled out. Unfortunately, there are several huge disadvantages to the threshold model. Much of the data necessary for accurate quantitative modeling of decision-making doesn't exist yet. Gaps left by the lack of data allow biases to affect estimates of disease probability. Even when the necessary data does exist, as you probably saw with this UTI example, applying it rigorously to an individual patient is time-consuming and often impractical. In short, the threshold model is not something that individual clinicians use to make conscious, individual decisions in everyday practice, but rather it's a tool to help understand the decision-making process in general and can help with the design of decision support tools. So how do doctors usually make rational decisions in practice? Heuristics and clinical prediction rules, which admittedly suffer from their own problems. There is one special case in which the threshold model is not applicable. Sometimes additional testing is unjustifiable despite multiple diagnoses still being possible. This is true when all of the remaining diagnoses on the differential are benign and either self-limited or with very low-risk treatment that can be tried empirically. This can be unsatisfying to the patient and clinician alike, but it is an unfortunate limitation of diagnostic reasoning. Today's key takeaways. A diagnosis is ruled out or ruled in when its probability is low or high enough, respectively, that the balance of anticipated benefits and harms argues against further testing for it. A ruled out diagnosis has a probability greater than 0%. A ruled in diagnosis has a probability less than 100%. The threshold model provides a theoretical framework to guide clinical decisions despite the presence of uncertainty. And unfortunately, the threshold model is impractical to use precisely in most real-world situations.